Hello, everyone. One of the most outstanding features of Israeli healthcare is its commitment to equity, which means that people should get good access to good care, irrespective of how much money they make and whether they're part of a minority group or whatever. This has been true for decades in Israeli healthcare. And today we're going to hear about a pioneering effort to move this ahead even further. I'm Bruce Rosen of Israel Healthcare Highlights, and my special guest today is Professor Rachel Wilf-Miron of Tel Aviv University and the Gertner Institute. Rachel, welcome.
Welcome. Thank you, Bruce, for inviting me. I'm really honored to be here.
That's great. We've known each other a long time, and everybody in Israeli healthcare knows you, but we have viewers from London and from Paris and from New York. So please, for those few who don't know you, please give us some background about yourself.
Sure. I'm a physician, board certified in pediatrics and medical administration, both from the Sheba Medical Center. Over the last 20 years, my major activity and passion is the promotion of equity in health and health services and health outcomes. I'm involved at three levels: developing and teaching a unique course dealing with reducing health disparities for MPH students at the School of Public Health in Tel Aviv University, research activities that focus specifically on the top of health disparities, and incorporating an equity compass into my current role in the field of health policy.
That's great. So how did you first get involved in this equity issue?
My first field activity to promote equity was at the Central Administration of Maccabi Healthcare Services, the second largest HMO in Israel. Some 20 years ago, as the Chief Quality Officer of Maccabi, I gradually learned about the unacceptable disparities among population groups and regions. For example, Arab women aged 50 to 74 olds utilize screening mammography for early detection of breast cancer 3 times less compared with Jewish women in Maccabi. The exam was offered free of charge, and yet the gaps were enormous. Following such examples, which are many, I led with a multidisciplinary team the analysis of socioeconomic, geographic, and ethnic disparities in health processes and outcomes. Since Maccabi is not a research institution, but a service provider, we formulated a set of recommendations that were presented with the data analysis to all HMO senior and mid-level managers. This led to the adoption of health equity as a core strategic value at Maccabi.
That's great. And I think it really expresses how in Israel, equity is not just important to the national government people or the people in academia, but really to the service provider organizations and the individual professionals. I know that another major activity of yours in past years has been dealing with waiting times, which is a real problem in Israel. And I understand the equity comes into play there as well. So could you tell us a bit about that?
Since 2018, I serve as a director of the National Program of Wait Time Measurement in Healthcare. We have developed methodology and infrastructure for measuring wait times in healthcare at the national level. That was not simple, and for years, prior efforts to do that did not succeed. We have achieved routine measurement for 10 community-based specialties and are now close to finalizing efforts to measure wait time also for 24 elective surgeries in all Israeli general hospitals. We will be able soon also to compare our results with the OECD countries. Using a geographic information system-based site, the Ministry of Health reports wait time across regions and areas to the public and policy makers on a quarterly basis. We analyze disparities in care process and access, identify bottlenecks and barriers, and crystallize them into recommendations for the entire healthcare system, the HMOs, and the administration of the Ministry of Health, in order to decrease wait time and reduce disparities. We know from Brookdale and other surveys done in the last years that long wait time have been repeatedly reported by Israelis as main reason for utilizing private medical services, and it's now very clear that if we shorten wait time and reduce disparities in wait time, we can strengthen the public healthcare system, and increase equity.
So are there big disparities between parts of the country in terms of waiting time?
Yes, in some of the specialties like orthopedics, the southern periphery, Beersheba area, Ashkelon, Sderot, people who live there would have to wait twice as more time,
Wow.
as longer wait time compared with the central areas or the northern, where, by the way, in the northern periphery, wait times are relatively short compared with the southern, but also with the national average. In other areas like dermatology, the central area is characterized by larger weights. So it's not always disparities between periphery and center. In some cases it is, like orthopedics.
Great. It's so great that you're working on it. I know from personal and family experience, even though I live in Jerusalem, which has a lot of care providers, waiting times can sometimes be terrible and the uncertainty involved. I'm so glad you're working on that. Now let's turn to your more recent work on developing national equity indicators. Please tell us about that.
Sure. Due to considerable socioeconomic and health disparities, the Ministry of Health has defined health equity measurement as part of its strategic health plan. I had the privilege of leading, together with my colleagues at the Israel Society for Quality in Healthcare, the Ministry of Health's initiative of developing a national set of health equity indicators. With the considerable support of the professional guidance of the National Institute of Health Policy Research, and with partners like the ICDC and diverse Ministry of Health divisions, we conducted a process in the years 2019 and to 2020. First, we identified appropriate and available equity measures via interviews with stakeholders. Then we formulated a set of 4 screening or scoring criteria, which were potential for change, public health importance, the characteristics of the disparities, and the interest of the public. And we agreed on their relative weighting. Finally, we constructed a consultation framework as an online 3-stage Delphi technique with a range of experts recruited from the health, welfare, and educational sectors. We also invited patient and public representatives. Participants were from varied backgrounds, gender, ethnic groups, and geographic regions. Because
I'll just interrupt you there for a minute. I'll just
measure.
interrupt you for a minute to say that I was one of that large panel of people who were asked to participate, and this was a very serious, very professional, very rigorous process. So, chapeau.
Thank you. Out of the 77 experts and public representatives that were contacted, 75, which is amazingly high proportion, were willing to participate. They were guided to reach a consensus using the 4 screening criteria, over 30 inequity indicators that were presented to them via the Qualtrics, a computerized platform. 55 of the participants, which is 73%, completed all 3 scoring rounds. And I should say that in the second and third round, we were confronting the beginning and the peaks of the COVID-19 pandemic, and I thought it will ruin the process. But I realized today, after analyzing what worked and didn't work, that probably the importance of the matter that was scored or developed was so important to participants that they participated and gave their vote or scoring despite what the burden that was put on them during the pandemic. 10 indicators achieved the highest scoring with good agreement among raters. They represent preventive and chronic care as well as health system factors. For example, diabetes care, childhood obesity, ability to afford care, a distribution of healthcare personnel, and infant mortality. One of the important, to my point of view, measurements that were included in the 10 top measures was access to psychotherapy, which is a real trouble in Israel. The public health, mental health care services were under terrible stress even before the Iron Swords War, which put extra stress on the mental health care services. All those indicators were important. For example, let's look at one example. Infant mortality, in the latest data that we have from 2023, is 2.7 higher among Arabs compared with Jewish infants. That's despite considerable efforts during the years to reduce this disparity. All chosen indicators were adopted by the Director General of the Ministry of Health to be monitored and gradually reported from 2023 onwards in a yearly health disparity national report. I believe that the active participation of diverse audiences, including influential stakeholders, in the consensus process increased the chances of implementation of those newly adopted equity indicators. I hope that this will help the healthcare system to focus on what is most important and deserves attention and resources in the quest towards a more equitable healthcare system.
Rachel, this is amazing. To what extent do other countries have this kind of rigorous system for monitoring equity?
The British were among the first one. They have even divisions that deal with health equity, and they put like 20 years ago a target to reduce the disparity in infant mortality by, I don't remember the exact percent. By the way, they didn't manage, I mean, they didn't reach this target. And in the Marmot review after the COVID pandemic, he said that one of the reasons why British population was so severely hit by the COVID is that there were such great disparities and that we have to do it better when we get out of the pandemic. I know that all the countries do, the Scandinavian countries and other countries, they do. I am not sure if they have a national measurement system, but they refer to disparities as part of the quality measurement.
Okay. I think we can all see from this brief time together with Rachel that when there's something important and complicated to do in Israeli healthcare, Rachel is really your person for it. She's worked on some of the biggest issues, the quality measurement, the waiting times, the equity measurement, really one thing after another. Rachel, before we wrap up, do you have any parting words for our audience?
I say that since the WHO report on social determinants of health published in 2008, we understand that inequity in access to healthcare, education, decent work, and living conditions are the major contributors of health and inequity. We could say in the healthcare system, why bother if nobody is able to decrease those disparities, the social determinants that are major contributors of health inequity? Can we do something? I believe we can do a lot. We can do a lot within the healthcare system, and we can do a lot by recruiting other ministries like the Interior, who is responsible for the local authorities. And indeed, in the last year or two, great work is done to recruit leaders within the local authorities to work on reducing disparities in health.
That was great. Lots of information and very inspiring. Thank you so much for joining us here today, and thank you for your decades of dedication and accomplishment in Israeli healthcare.
Thank you for the compliments, and thank you for allowing me to share this with your audience.